So, hi friends, I'm Dr. Anshul Bansal. Welcome back on the Unacademy platform. In today's YouTube live session, we'll continue the marathon MCQ practice part that we had left in the previous session. So, this will be again a marathon MCQ session where we'll discuss lots of question and our special focus will be on question only. Okay, so this is very helpful for the FMG aspirants as well as the INICT aspirants as well as the NEET PG 2022 aspirants. सब लोगों के लिए this is very important because question practice is the most important thing to crack any competitive examination, and it is the most valuable way and the best way to revise any topic. Okay, so don't fear of doing questions ki yes मेरे को question नहीं आएगा, so I will get anxious. No, this is the best way to revise, because not only revision, you also get to know that which topics are more important and what are the types of questions that are being asked. So please do question practice ज़्यादा से ज़्यादा. It is the most important thing. Okay, so currently I'm working as an orthopedic house surgeon in SMS Hospital Jaipur, and I've cracked the NEET PG examination last year, that is in 2020 only. So before starting this session, I will just briefly guide you about our various subscription plans that are available for the NEET PG on Unacademy. Okay. So the first subscription plan is your Plus subscription. Plus subscribers will get access to all our live as well as recorded classes. They can access our entire QBank, and they can compete in live tests and quizzes, all of which is found by the topmost faculty for the NEET PG in India. And also we'll allow the subscribers to log into multiple devices with the same account, so that they can study on any device of their choice at any time. And also we'll allow the subscribers to those who have subscribed for 12 months or more, they are shortly getting their printed notes. So while subscribing, you can use my code, that is Anshul B10, to get extra 10% off. The second one and the best one is your iconic subscription, and it is best not only on the Unacademy platform but across any digital platform for the NEET PG in India. And what makes this best is that apart from the things that I've told you earlier, that is all the benefits of the plus subscription will be there. In extra may here you will get the prep ladder and all of the prep ladder, including its entire QBank, the video lectures, rapid revision courses, grand test, etc. And on Unacademy extra may you will get well structured live batch wise classes, and we have formulated our batches and structured a course in such a way so as to build up your basic concept about any subject or topic first, then going into its in depth. Also, the iconic subscribers will get an individual test assessment sheet after every test that they'll give, so that they can analyze themselves key as this topic or this subject needs more revision. Yeah, what are the things that are asked frequently in examination yeah, from a particular topic, what are the things from which questions are formed. Okay, so all this is very important, and all this you get in the iconic subscription. And while subscribing, you can use my code, that is Anshul B10, to get extra 10% off. Okay. Special classes are very special because they'll give you extra edge over your competitors, and you will get a live classroom like feeling where you can interact with your educators, participate in polls, clear your doubts there and there only, and you can watch the special class anywhere, anytime. What you have to do, you have to just download the mobile application and log in into that mobile application of Unacademy using my code, that is Anshul B10, and both of which are absolutely free. So every special class is absolutely free. You just need to download the mobile application and log in, and after every special class that you will attend, you will also get the digital notes of that special class. Okay, so today at 9 p.m. I've scheduled a special class on the ligaments of the knee, a very important topic and sometimes a difficult topic to understand, but in a simplified form we'll study it today in this special class. And also we have launched a QBank, and our question bank contains every type of question that is important and that might come in the examination. Our question bank includes all the recall questions and the questions which have been asked in the previous year's examinations, the questions based on images, CT, MRIs, X-rays, histopathology slides, recent advances, and very importantly, questions based on clinical scenarios and the clinical case-based questions. All these are included in a QBank. So please do solve a QBank. Okay, this is also a marathon MCQ session also, where we will solve lots and lots of questions. So please do make a habit of solving questions. Okay, and we have also launched a new feature which is called as raise a hand feature, in which you can interact with your educators in the live class, clear your doubts, discuss your queries. And we have launched this feature to make this digital platform more interactive and to increase the communication between our learners and our educators. These are the various subscription plans on an academy for the plus as well as the iconic subscription. And here you can see that the cost per month decreases significantly if you increase the duration of your course. So economically it is beneficial, and also academically it is very important for you to have a subscription plan with longer duration, because you want to have a single source of information from the starting of your preparation, so that you don't have to hop around or study different topics or different subjects from different digital platforms, because this will make your because this will make your revision and concept building very difficult. So while subscribing, please go for the subscription plan with longer duration, and you can use my code while subscribing, that is Anshul B10, to get extra 10% off. Okay, so let's start today's session. After every question I'll give you appropriate time, and then you can write your answer in the live chat box, and then we'll discuss the question and the all the options of that. Okay, so these questions we have already discussed, so I will not discuss them again. Foot drop, yes, we had discussed. Scissoring gait, we had discussed. Embolism, Bryan's traction, we had discussed. Okay, so we'll start with this question. Okay, so the first question is, a 50-year-old male had an accident and presented with internal rotation, adduction, and flexion of the hip joint. What is the diagnosis? So here are your 30 seconds for this question. Okay, so we have discussed many a times that most common joint to get dislocated in the entire body is a shoulder joint, and this may be the anterior dislocation is most common, and anterior dislocation may be the subcoracoid type of dislocation is the most common. In case of hip joint, most commonly posterior dislocation is there, in which the head of the femur is dislocated posteriorly, that is, it is upwards and lateral of the acetabulum. So the force will be in this direction, that is anterior to posterior direction may the force of the due to which dislocation occurred will be there. So what this direction? So obviously if the head is posterior, the limb will come into the internal rotation, adduction, and the flexion pattern. So this is your posterior hip dislocation, whereas in anterior dislocation sorry, in anterior dislocation there will be external rotation and abduction. Okay, IT femur, fracture neck of femur, in maybe there will be external rotation. Okay, so the answer for this question is a posterior hip dislocation, very important. This year also in NEET PG 2021 there was a question on posterior dislocation of hip. Okay, and treatment of any dislocation in the body is your close reduction followed by maintenance, and in this case in hip joint the maintenance is by the traction. Okay, and close reduction के लिए you have two maneuvers. Just remember the name for the hip joint, that is your Bigelow's maneuver and your Watson and Jones maneuver. Okay, remember this is again important. Okay, so here you can see the head of the femur is this is your acetabulum, and here you can see that the head is out of the acetabulum cavity and it is dislocated upwards and laterally, that is your posteriorly. So this is a x-ray of posterior dislocation of hip joint. And which hip joint? Left hip joint. This is your left side, this is your right side. Okay, so this is your dislocation. Now next question, jersey finger is due to. Here are your 30 seconds. Okay, so what is jersey finger? This is your jersey finger, my index finger. Okay, that means that in jersey finger you will be unable to flex the finger at distal interphalangeal joint, that is the DIP. So means there will be an injury to the flexor tendons, and it may be the most commonly the attachment or insertion of the fibers of the flexor digitorum profundus at the distal phalanx. They are avulged or torn, so this will lead to the jersey finger unable to flex at the distal interphalangeal joint. So the answer will be fourth, that is your flexor digitorum profundus. Okay, remember this. And iska opposite is your mallet finger. Okay, इसका opposite is your mallet finger, where you will be unable to extend the finger at DIP. Okay, extend the finger at the DIP. So obviously there will be avulsion of the extensor tendons at the distal interphalangeal joint. So mallet finger and jersey finger, in दोनों में differentiation you have to remember, and it is very easy. Okay, so this is your jersey finger that we had already discussed. Okay, see, unable to flex. So this is your jersey finger. Okay? This is your jersey finger. Now next question, sunburst on x-ray seen in all except. Here are your 30 seconds. Okay, so sunburst वैसे it is, as you all know, sunburst or sun ray appearance is a characteristic feature of osteosarcoma, but here all except. So what the examiner is trying to ask you, the examiner is trying to ask you about the periosteal reaction, because sunburst is a type of periosteal reaction in which it is intense and irregular, whereas in Ewing sarcoma or in chronic osteomyelitis etc., there is also periosteal reaction, but in those cases this periosteal reaction is not that intense, firstly, and secondly it is not irregular. Okay, in Ewing sarcoma there is onion peel like appearance in form of layers. There is periosteal reaction. Okay, so sunburst appearance the examiner is asking, that means he wants to ask about the periosteal reaction. So amongst these four options, the options where periosteal reaction does not take place, that is the new bone formation does not takes place, it is your answer. Okay, so in osteomyelitis, chronic osteomyelitis, yes, it is there in the form of involucrum. Cloaca is discharging sinus, involucrum is new bone formation, and third is your sequestrum, that is dead bone. In osteosarcoma, obviously you will have this. Ewing sarcoma also you have this. In hemangioma, you does not have the periosteal reaction. So the answer for this question will be fourth, that is your hemangioma. Okay, so remember this. Don't get confused कि sun ray appearance तो सिर्फ osteosarcoma में होती है. Yes, but here the examiner wants to ask about the periosteal reaction. Okay, so remember this. So the answer for this question will be your hemangioma. So hemangioma may what you will see in the vertebral columns, the vertical striations will become more prominent, whereas the horizontal striations will disappear. Okay, this is your Codman's triangle, which is the initial stage of the periosteal reaction, where the new bone forms this triangle kind of thing called as the Codman's triangle. Okay, this is your sun ray or the sunburst appearance of the osteosarcoma. Okay, Ewing sarcoma mein, here you have the onion peel appearance of the periosteal reaction. See, this is your Ewing's sarcoma. Okay, osteosarcoma we have discussed, Codman triangles, onion skin layer we have discussed. So sunburst appearance in osteosarcoma, lamellated or onion in Ewing sarcoma, like this lamellated or the onion. Okay, and this is your Codman's triangle, the initial phase of new bone formation, that is your periosteal reaction. Okay, now next question is complete undisplaced fracture of femoral neck is. Here are your 30 seconds. Okay, so complete undisplaced fracture neck of femur. So neck of femur में you have three classifications which are important. First is your on the basis of location of the fracture line. Okay, they are of three types: the subcapital, the trans cervical, and your basi cervical. And subcapital is most near to the head, that is the most proximal one. Uske niche trans cervical, and the most distal one just above the trochanters is your basi cervical. Okay, now second is your Powell's classification, which is based on the Powell's angle. It is an angle formed by the superiormost line, that is the superiormost line touching the neck of the head of the femur, like this. Okay, and this is your fracture line. तो उसके बीच में जो एंगल होता है, दिस इज कॉल्ड अ Powell's एंगल, एंड बेस्ड ऑन दैट देयर इज अ क्लासिफिकेशन विच इज कॉल्ड एज Powell's classification. Now, so इसमें complete undisplaced fracture, it is based on angle. So third and fourth is not the option. Now, third and the most important is your Gardens classification, and this Gardens classification is based on the rotational displacement. Yeah. This Gardens classification is based on the rotational displacement. It is of four types. Okay. So in type 1 you have a incomplete fracture called as the impacted neck of femur fracture, and only this type of fracture can be managed conservatively. Rest all femur neck of femur fractures may you have to go for the surgery. So in case of young adults or only adults also, you have to go for the surgery by the corticocancellous screw or the DHS, whereas in the elderly population, that is above 50-55 years of the age, you go for the bipolar hemiarthroplasty. Okay, so in type 1 of Gardens you have the incomplete fracture. 2, 3 and 4, there it will be complete fracture, but in type 2 complete but undisplaced, whereas type 3 and 4 are complete but they both are displaced. Okay, now in type 3 the head still have a contact with the remaining neck or the shaft of the femur, whereas in type 4 head have no contact with the remaining part. Okay, so here complete and undisplaced, that is type 2, that is Gardens type 2. Okay, so the answer for this question will be option 2 or option B, that is your Gardens type 2. Okay, this is your Gardens classification of the fracture neck of femur. It is type 1 incomplete, type 2 complete but displaced, type 3 complete but undisplaced, type 3 is complete plus displaced, but displacement में there will be some continuity between the fracture ends, whereas in type 4 here you can see there is no continuity between the fracture ends, so it is completely displaced. This is your Gardens type 4. Okay, remember Gardens classification is very important. Okay, now we'll come to the next question. Next question is, test for injury of anterior cruciate ligament is. Here are your 30 seconds. Okay, so see, in knee we have six important ligaments: the anterior and the posterior cruciate ligament, which prevent the anterior and the posterior dislocation of the tibia, respectively. Second is your medial and the lateral collateral ligament. As name say, you can easily guess ki they will prevent the medial and the lateral subluxation or dislocation of the tibia or the knee joint, respectively. And your third group is your menisci, that is medial menisci and your lateral menisci, which act as a cushion for the rotational stability. They act as a shock, they act as shock absorbers. Okay, so these are the six ligaments of the knee, very important, and इस पे detail में we have a class, special class today at 9 p.m. Okay, so anterior cruciate ligament का test जो होता है, drop back phenomena, dial test, pivot shift test, all of the above? So the answer is all of the above. So what are these tests? See, this is the anterior cruciate ligament, that is it attaches to the anterior part of the proximal tibia, but the posterior part of the distal femur. Okay, and iska ulta will be your PCL. So that's why they will form a cross in three-dimensional. So this is called as your cruciate ligaments. Okay, these are your medial and the lateral collateral ligaments, because fibula is laterally. So this is your lateral collateral ligament, and here you can see the cushion. This is your cushion or the gadda or the shock absorbers. These are your menisci. Okay, the medial and the lateral menisci. Okay, now four classical symptoms, and remember generally medial collateral ligament and medial menisci both get injured together. Okay, both get injured together. Okay, so whenever a ACL is torn, there will be anterior instability. So there will be first of all a pop sound, and you will have a feel that the knee is giving away, that is the knee is dislocating towards the anterior side, and there will be intense swelling, pain, inability to bear the weight etc. Okay, so severe pain etc, it will be there in case of ACL injury. Okay, so now dial test you can do like this. Okay, for the PCL as well as the ACL. Okay, and this is your pivot shift test, also called as the Macintosh test. Pivot shift test or the Macintosh test for the ACL anterior cruciate ligament, and drop back test, which is called as the Goodfried's drop back test. Okay, now next question. Man 26 years old having pain with daily stiffness of the spine for 35 minutes with reduced chest movement. Which test is not done? Here are your 30 seconds. Okay, so all these are directed towards the diagnosis of ankylosing spondylitis. Okay, very important, ankylosing spondylitis. Okay, and how we have made the diagnosis? So सबसे पहले age 20 to 30 male, so male 26 years. Okay, with pain and stiffness. Okay, and reduce chest movements, reduce spine movements etc. And इसके pain में there is one characteristic feature, that the pain increases on rest and the pain decreases while work or walking etc. This is a characteristic feature. The first most common or the earliest joint to be involved is your sacroiliac joint. So there is sacroiliitis in the starting. Remember this, there is your sacroiliac joint that is involved सबसे पहले. Now ankylosing spondylitis आते ही you should remember two things, that is HLA-B27 positive होता है ये, and secondly you have to remember the bamboo spine or the dagger sign, because there is ankylosis, there is bony ankylosis, which will lead to the fusion of the spine and there will be no movement. Okay, so this is your ankylosing spondylitis. Now which test is not used, that is ankylosing spondylitis, which test you don't use? Flashe test, yes you use. Pump handle test, yes. Faber test, yes. Ober's test, no. So the answer is your Ober's test. Now अब ये test कौन से होते हैं? So remember, Fleischer's test is used if cervical spine involvement is there. Pump handle for the sacroiliac joint you use. Okay, so this is your Fleischer test or the occiput to wall distance. So normally if you stand एकदम straight with your heels against the wall, Here you can put your occiput or you can touch your occiput at the wall, but in case of involvement of the cervical spine, there will be ankylosis, there will be stiffness. So you can touch your occiput only while by raising the chin. Okay, so this is your Fletcher test. Okay, uh, the patient is there to extract. So this is your Fletcher test. Normally, the distance between occiput to wall should be 0. Okay, so for the cervical spine, this is your pump handle test. Okay, for checking the sacroiliac joint, and isme if the tested part is outside the table, okay, then it is called as your Ganslin's test. Like this is called your Ganslin's test. Okay. Now Patrick's test or Faber's test, the limb is placed at the hip joint with the hip joint flexed, abducted and externally rotated like this, and if there is a pain, then this is called as a positive. So used for the ankylosing, the Patrick test or the Faber's test. Okay, इसके बाद Ober's test, it is not used for the ankylosing spondylitis. Okay, it is generally used to check the hip deformities, and especially for the checking the tensor fascia lata. Okay, this is your Ober's test to remember. And इसके अलावा if there is involvement of the ribs or the costochondral junctions in ankylosing spondylitis, you use the test called as the chest movements. Okay, in inspiration and expiration के time पे you measure the diameter, the circumference of the chest to chest. Now next question, one liner question: which is the strongest ligament in the body? And here are your 30 seconds. Okay, so the strongest ligament in your body is your A, that is the iliofemoral ligament. Okay, it is your iliofemoral ligament. Now, next question, a very important question. True about osteoclast, all except. Here are your 3 seconds. Okay, so always remember, सबसे पहले विटामिन D3, it increases serum calcium as well as phosphate. Calcitonin decreases both, whereas the parathormone increases serum calcium and decreases serum phosphate because it increases the excretion of phosphate from the urine. Okay, so vitamin D increases resorption as well as it increases the new bone formation, whereas parathormone increases only resorption, and the major hormone related to the a resorption is your parathormone. Okay, so it is correct. And also the major cells out of osteoblast, osteocytes and osteoclasts, the major cell related to the resorption is by the osteoclasts. Okay, so कोई आपसे पूछे parathormone is responsible for the bone resorption? Yes, correct. Osteoclasts are the most important cells and they are responsible for the resorption, then it is correct. Now if you are asked if parathormone is stimulated by stimulates the osteoclast or osteoclast stimulated by the parathormone, then this is wrong. because directly parathormone has no receptors on the osteoclast. They does not directly stimulate the osteoclast. First of all, this parathormone will stimulate the osteoblasts, which will they have the receptors. They will proliferate, and with the help of rank ligand, the receptors are present of this on the osteoclast. So the osteoclast will be activated. There will be proliferation or activation of the osteoclast. They will convert into the osteoclast with ruffled borders, etc., and they will do the bone resorption. So osteoclasts are multinucleated giant cells derived from the monocyte macrophage lineage. So yes, this is correct. Phagocytosis of foreign bodies, yes, this is also correct. Resorption of bone, this is correct. Stimulated by the parathormone, no. Parathormone directly stimulates the osteoblast or the osteocytes first. So the answer will be B. Okay, this is a very important concept that you should remember. Okay, that parathormone does not directly bind to the osteoclast. Now, to check this resorption, okay, there is a inbuilt mechanism, and that mechanism is based on OPG, that is osteo proteagranin. And this osteoproteagranin is a competitive inhibitors which bind to the rank ligand wali sites. Okay, so it is a competitive inhibitor of the rank ligand. So if resorption is uncontrolled and resorption is bahut zyada, then the OPG will get bind to these sites and it will decrease the resorption. Okay, so this is a check mechanism to check irregular and increased bone resorption. Okay, this osteoproteogranin we have already discussed. Now next question is, 12-year-old child developed pain in the lower leg with trivial injury. The x-ray is given. What is the diagnosis? Okay, so 12-year-old child, and the x-ray is given. So this x-ray here, it is looking like a cystic lesion, and it is a bone cyst, and that too a simple bone cyst called as the unicameral bone cyst. Okay, so traumatic fracture, no, it will not be there, because this cyst will make this bone weak, so there will be chances of pathological fracture. So pathological fracture due to non-ossifying fibroma, yes, this can be non-ossifying fibroma also. Okay, due to osteosarcoma, no, that is not osteosarcoma, because here you will have the sun ray sunburst appearance and not this globular lytic lesion. Pathological fracture due to aneurysmal bone cyst, no. Aneurysmal bone cyst may the loculated appearance will not be there. There will be more and more air, so more blackish or more lytic lesion it will be there. So this is not the answer. Now you are confused between simple bone cyst and the non-ossifying bifibroma. Simple bone cyst is not given in the option, so the answer is second, that is your non-ossifying fibroma. Okay, which later on converts into the osteoid osteoma. Okay, so this is your non-ossifying fibroma. Okay, which will lead to the pathological fracture in this case. So the answer will be B. Okay, here you can see that non-ossifying fibromas are multiloculated. They have a sclerotic rim, eccentrically placed. Okay, most commonly in the metaphysis, most commonly in the metaphyseal area. Okay, what is this? This is your non-ossifying fibroma. This is a non-ossifying fibroma here. This is the osteosarcoma, the lytic pattern, the sclerotic pattern, and the mixed pattern. Aneurysmal bone cyst. Aneurysmal bone cyst is also eccentric in location, and it is at the junction of metaphysis diaphysis के junction पे होता है most commonly. There is sclerotic margins. Okay, this is your aneurysmal bone cyst, and here you can see no, not that loculated, more blackening, more air kind of thing. Okay, so this is your aneurysmal bone cyst. Okay, now next question. Next question is, what is Tom Smith septic arthritis? Here are your 30 seconds. Okay, so Tom Smith septic arthritis is arthritis in infancy. Okay, and that to the pyogenic one, and that to the infection of the hip joint, and it is painless. These are the characteristic features of Tom Smith septic arthritis. Okay, so Tom Smith septic arthritis is arthritis in infancy and of the hip joint. Okay, if the hip joint, what are infants? Infants less than 1 year old child, it is your infant. Okay, so this is rapidly progressive disease. There will be rapid as well as बहुत सारा abscess formation, and which may burst out from the soft tissues and the skin, or if it is identified early with the help of proper antibiotics, you can treat them without IND also. Telescopy test will be positive, so that's why it is similar to the congenital dislocation of hip, that is CDS, and most commonly in CDS as well as, that is congenital dislocation, as well as uh, this septic arthritis may you might have a dislocation of the femur head at the hip joint, and this is posterior. Okay, in both the conditions it is posterior, so that's why this condition resembles congenital dislocation of hip. तो दोनों में मेन डिफरेंशिएटिंग फीचर जो होगा दैट विल बी द साइंस ऑफ acute inflammation. Okay, so septic arthritis of hip joint in infancy. Here you can see that almost entire epiphysis is gone. Okay, this is your septic arthritis. Now, second, no, sorry, the next question is, fallen fragment sign is seen in very easy and typical question. Here are your 30 seconds. Okay, so the fallen fragment sign is the characteristic feature of simple bone cyst, also called as the unicameral bone cyst. Okay, this is your unicameral bone cyst. This is seen case of, yes, this is a typical feature of a simple bone cyst or the unicameral bone cyst, where you have this fallen fragment sign here, which might cause the pathological fracture. Okay, this is your simple bone cyst. Okay, there is a presence of bone fracture fragments which is seen in the cystic bony lesion. Okay, simple bone cyst, and it is benign only. Prognosis is very good. Excision is the treatment of choice. Okay, now next question. Next question is, You are posted as an intern in casualty. Which among the following complaints with fracture will be your first priority to call Ortho PG and inform? Here are your 30 seconds. Okay, so during reimplantation, first priority. So first priority in casualty is your head injury, thorax, or the abdominal injury. This is your first priority. Second is your any neurovascular injury, injury to the nerves or the artery, major artery, etc. The neurovascular injury is your uh, second most important or the priority wali thing. Okay, and iske baad you go for the priority is your fracture shaft of femur, fracture pelvis due to two things. First of all, due to chances of hypovolumic shock, as we have discussed. Shaft of femur, there will be chances of fat embolism, etc. So first priority will be your head, thorax, abdominal injury. So there is no, so fingers, patient's finger is blackening. This means there is some injury to the vessels. So yes, this can be the answer. Finger patient can't extend the arm, 100 per centimeter abduction, and intra-articular fracture of elbow joint. इन सब में से the first priority will be your neurovascular injury, that is your patient's finger is blackening. Okay, so the answer for this question will be A, that is patient of finger is finger of the patient is starting to grow black. In rheumatoid arthritis, which type of cells are predominantly present? Here are your 30 seconds. So rheumatoid arthritis is, it is a type of inflammatory arthritis. Okay, it is a form of inflammatory arthritis, that is a rheumatoid arthritis where there is auto antibodies against the self antigen, and in this case the self antigen is IgG antibody, that to the FC part of the IgG antibody. Okay, this is your inflammatory arthritis में rheumatoid arthritis. Okay, now which cells are predominantly, they are the macrophages or monocytes. So the answer here will be C, that is your macrophages. So these macrophages are the most predominant cells. Okay, normally the synovial lining, we have discussed कि rheumatoid arthritis में the basic pathology is in the synovial membrane. Okay, and in case of osteoarthritis, the basic pathology is in the articular cartilage. Okay, this articular cartilage ka degeneration and destruction begins first in osteoarthritis, whereas in rheumatoid arthritis, all these features are firstly in the synovial membrane, and when there is hypertrophy, it will lead to formation of the pannus, which will destroy the joint completely. So normally the synovial membrane is only 1 to 3 cells thick, but in case of pannus formation and rheumatoid arthritis, it will be more thicker, that is hypertrophied 8 to 10 cells thick हो जाता है, and the majority population is for the macrophages and your fibroblasts. Okay, macrophages and your fibroblast. Now next question, first you read the question, then we'll discuss it again साथ में. I'm giving you 60 seconds for this question. Okay, so the patient has a history of RTA 2 years back at the same site where he developed pain and swelling. X-ray shows the following features. What will be the diagnosis? Okay, so road traffic accident. 2 years back there was a injury at the knee joint. Okay, and till now also there is pain and swelling. So uh, what will be the diagnosis? Okay, so RTA है, this pain swelling. So osteogenic sarcoma is not, Ewing sarcoma is not there. Chronic osteomyelitis and multiple myeloma है सकता है, and multiple myeloma also does not occur in case of road traffic accident. So it is a chronic osteomyelitis. And how? Because there is a focus of infection here due to the good immunity of the body. It get localized here, okay, and does not spread and involve the entire part of the bone. Okay, so this is your chronic osteomyelitis or the Gary's osteomyelitis, Gary's sclerosing osteomyelitis. So what is the difference between Gary's and septic osteopyogenic? In Gary's osteomyelitis it will be non-suppurative chronic osteomyelitis. It will be non-suppurated chronic osteomyelitis, and very important is that there is no discharging sinus. There is no the clinic characteristic or the pathognomic feature of chronic osteomyelitis is your presence of discharging sinus out from the skin. But in case of Gary's sclerosing osteomyelitis, there will be no discharging sinus. Okay, this is your Gary's osteomyelitis. Okay. Now, the chronic osteomyelitis में you have three parts in pyogenic chronic osteomyelitis. The sequestrum, which is the dead part, and remember this sequestrum is not decalcified even after becoming dead. Okay, so there is no decalcification. So X-ray के अंदर these sequestrum will look like a white line, that is the intense line. This is called as your sequestrum. The second is your involucrum, which is the new bone formation, and this involucrum is involucrum surrounds the sequestrum, whereas the sequestrum is surrounded by the involucrum. One in the same thing. So remember, sequestrum is inside and involucrum is outside. Okay, and the third feature is your cloaca, that is your discharging sinus from the bone, not the skin. अगर bone से है the discharging sinus, it is your cloaca. And when out of the bone this क्या होता है, there is from the bone due to intense periosteal reaction etc., or the accumulation of the pus, there is break in the periosteum, and they will the pus will get accumulated in the soft tissue. There will be abscess formation, and then this abscess will get break, and it will burst out from the skin. That is called as your discharging sinus. So cloaca is different, discharging sinus is different. Cloaca is a type of discharging sinus, but it is in the bone only. These three are the characteristic pathognomic features of the chronic osteomyelitis, and उसमें भी the characteristic feature, the single most important characteristic feature is your discharging sinus, that is your cloaca. Okay, now we'll come to the next question. Next question is, what is meant by perilunate dislocations? Okay, so here are your 30 seconds. Okay, so remember, most common dislocation in the knee joint is your lunate dislocation, and इसका counterpart is your perilunate dislocation. Okay, so remember कि lunate dislocation में क्या होगा, the lunate will be dislocated, baki rest all carpal bones or the distal end of the radius etc are all in the same normal anatomical position in a single line, so they will be normal. And its opposite, that is lunate normal, rest all carpal bones are out of their plane, that is they are dislocated. This is your perilunate dislocation. Okay, so now we'll read the options. Lunate and capitate both in the same plane, yani koi dislocation is not there, it is wrong. Capitate in alignment and lunate out of the plane, this is your lunate dislocation, so this is wrong. Lunate in alignment and capitate is out of the plane, yes, it is true. Both lunate and capitate out of the plane, no, so the answer will be your C, that is lunate in alignment. Okay. Yes, so this is your perilunate dislocation. Okay, so the answer will be C, not B. यहाँ पे the lower radius scaphoid capitate in alignment, lunate out of the plane. This is your lunate dislocation, not the perilunate dislocation. And यहाँ पे सिर्फ एक ligament you need to remember, that is RSC, that is your radioscaphocapitate ligament. Okay, very important. And इसके लिए lateral radiographs, lateral view of the x-ray is important to see this. Okay, so this is your perilunate dislocation. Now next question is, most vascular zone of the bone is, we have discussed this many times, very easy question. Here are your 30 seconds. Okay, so the most vascular zone is your metaphysis. Okay, here you have the hairpin loop or hairpin arrangement, due to which there is increased blood flow, but sorry, there is increased blood flow, or not flow, the amount of the blood is increased but the flow is less, so yani there is sluggish flow. ओके, सो इसकी वजह से क्या होगा, ब्लड विल बी मोर एंड द फ्लो विल बी लेस, दैट इज कॉल्ड एज योर sluggish flow. So this is that's why there are high chances of any infectious emboli to get lodged here and cause the infection. So that's why it is the most common site for infection or osteomyelitis etc. And remember, most important or the most important or the major blood supply of the bone, it comes from the nutrient artery. Okay, and remember, this nutrient artery enters the bone from the diaphysis. Okay, this enters the bone to the diaphysis. तो अगर single artery की पूछे, then nutrient artery, and it enters from the diaphysis. And overall metaphysis, epiphysis, diaphysis, which is the most vascular zone, then you have to go for the metaphysis. Most common site for infection or osteomyelitis, again it is your metaphysis. Okay, especially in the children. Okay, so this is your nutrient artery, which have branches going upwards and downwards, and here it anastomose with the epiphyseal and the metaphyseal vessels. Okay, and here you have the periosteal vessels, which supply the outer one third of the cortex. This is your periosteal vessels. Okay, nutrient artery. Now next question, very easy and very important. It is your tennis elbow is characterized by. Here are your 30 seconds for this question. Okay, so tennis elbow, what is this? Tennis elbow is lateral epicondylitis. This is your tennis elbow, and at the lateral epicondyle you have attachment of the extensor tendons of the forearm, and usme bhi the origin of the extender tendons. So the answer will be tendinitis of the common extensor origin. Whereas medial condyle pe the medial epicondylitis, it is your golfer's elbow, and in all these there will be maximum point of tenderness, a localized tenderness wali point hogi either on the lateral epicondyle or the medial epicondyle. So this is your golfer's elbow where there is tendinitis of the common flexor origin. Okay, so the answer for this question will be B. Okay, and isko test karne ke liye, in first of all pronation, then palmar flexion, and there will be extreme pain and tenderness over the lateral epicondyle, rest, NSAIDs, etc. And you have a special brace which is called as the tennis elbow brace for this. And एक और चीज remember, lateral means outwards, okay, or the outer condyle, and medial means inner wala. Okay, so remember this also. See, this is your tennis elbow brace. This is your tennis elbow brace, and here you can see that there is tendinitis and damage to the microfibers of the extensor uh, tendons. Okay, now next question is, a child presented to an orthopedic clinic with a limp. The surgeon suspected him to have a fixed flexion deformity of the hip. Which test should the surgeon perform to confirm this finding? So here are your 30 seconds for this question. Okay, so for the hip joint you have three T's. That is your Thomas test, Trendelenburg test, and your telescopy test. Okay, so telescopy test is used for CDH or any dislocation, this is your telescopy test. Now Trendelenburg test is your Trendelenburg gate where there is any hip deformity, etc. So the body tries to compensate it by pelvic tilt. So pelvis will be tilted towards the opposite, will be tilted of the opposite limb, that is the normal limb, whereas the rest of the body will get tilted on the affected limb. Okay, so this is your Trendelenburg test where you have the Trendelenburg gate. Now to test the flexion deformity, you have a specific test which is called as your Thomas test. Okay, so this is your Thomas test where you check the flexion deformity, and if there is any flexion deformity, if you will try to flex the hip joint, the buttocks will come upwards automatically. Okay, so this is your fixed flexion deformity. Okay, so Thomas test. This is Trendelenburg test sign we have seen. Now Nilaton test कुछ नहीं होता. There is a Nilaton's line from anterior superior iliac spine here to the ischial tuberosity. You have a line, and generally the head of the femur and the greater trochanter, they are just above this line. Okay, they are uh, just above this line. But if it is more superior, okay, then you will have a hip dislocation or fracture dislocation like this. So this is your uh, Dilatant's line. Telescopy test, we have already discussed hip telescoping test. Now next question. Trigger finger involves which joint? Here are 30 seconds. We had a special class session last evening only, that is yesterday, on soft tissue injuries, where we had discussed the dupuytren's contracture, decurrency, tenosynovitis, trigger finger, all such very important short topics. So you can watch that lecture. Wahan pe you will clear all your concepts. So first solve this question, that is trigger finger involves which. So trigger finger involves the metacarpopharyngeal joint. Okay. So remember what happens is that the flexor tendons of the fingers, they are as a form of pulley inside sheets. So initially the sheet gets tense. So there is formation of nodule of this flexor tendon. So what happens is that especially in the morning, if you flex the knee like this, sorry, the fingers, the fingers will get entrapped or locked in this manner only, like a trigger. Okay, so you have to mechanically manipulate it with the opposite hand and put the pressure so that it is unlocked and you can extend it again. Okay, so this is your trigger finger, and as the disease grows in the later stages, you might not be able to or do it by yourself. You okay, yeah, that is, you might not be able to unlock it. Okay, so at that level you need to perform the surgery, that is stripping of this sheet. Okay, so the joint which is involved in trigger finger, it is your metacarpopharyngeal joint. Okay, so the mouth of the fibrous digital sheet in which the flexor tendons travel as a pulley is at the level of the metacarpopharyngeal joint. Okay, so the answer is your MCP joint, very important. Here you can see the nodule in the tendon and in the fibrous sheet, they are traversing like a pulley. This is your trigger finger. Okay, now next question is true regarding Monteggia fracture is. Here are your 30 seconds. Okay, so Monteggia fracture dislocation, MUP, that is fracture of proximal one third of ulna with dislocation of the proximal radioulnar joint or dislocation of the radius head. Whereas इसका counterpart is a Galeazzi fracture dislocation, where you need to remember GRD, that is fracture of distal 1/3 of radius with dislocation of distal radioulnar joint. Okay, so this is your Galeazzi fracture. Now, so true regarding Monteggia fracture, yes, upper ulnar fracture with dislocated radial head. This is your correct option. This is your Monteggia fracture dislocation, and the treatment in case of adults is your surgery only. And what you do, you go for the ORIF with plating for the fracture of ulna and K-wire fixation after reducing or relocating the radial head. Okay, so this is your Monteggia fracture. Okay, this is your Monteggia fracture, and इसमें you have a classification system which is called as Bardo. So Bardo type 1, it is your extension type, which is the most common type, where the is the most common type, that is your extension type Bardo type 1, in which the distal fragment or the fractured ulna is displaced, where it is displaced anteriorly. Okay, with anterior displacement of the radius head. Whereas supracondylar humerus fracture may be most common was the extension type, but there the distal fragment was displaced posteriorly. Yahan pe also it is the most common is the extension type, but here the displaced fracture displacement is anteriorly. Bardo type 2, where the displacement is posterior, it is called as your flexion type, and it is also called as your reverse Monteggia fracture dislocation. Okay, reverse Monteggia fracture dislocation. Okay, remember this. Here you can see very easily, this is your fracture of proximal 1/3 of ulna with fracture dislocation of the radius. This is your radius. So this is your radius head. This is your distal radioulnar ligament, radial styloid, ulnar styloid. Okay, and this is your ulna, and ulna mein here you have, this is your olecranon. This is your coronoid process of ulna. Okay, this is your olecranon, and this is your coronoid process of the ulna. Okay, your Monteggia fracture dislocation. Now we'll come to the next question. Very simple question. Dinner fork deformity is seen in. The simplest question for today. डिनर फोक डिफॉर्मिटी सीन इन कूलीज फ्रैक्चर रिमेंबर सी के बाद क्या आता है डी so in Cooley's fracture you will have the dinner fork deformity, you will have the dorsal tilt which is called as your posterior tilt, which is the differentiating feature you of with the Smith. You will fall on an outstretched hand, elderly population, etc. And in case of Smith fracture, which is the counterpart, here you will have the no dinner fork deformity. You will have the dorsal ka ulta is a ventral, that is ventral or anterior or the volar tilt. It is due to fall on an inward hand like this. Okay, this is your outstretched hand pe fall and this is your inward hand pe fall. Okay, first, now similarities is both are common in adult population, and both are the fracture of the distal end of the radius at the corticocancellous junction, and both are extra articular fractures. Okay, both are extra articular fractures, whereas distal and radius ka fracture, which is intra articular associated with carpal injury, that is your part fracture. Okay, remember this. Okay, and another is gunstock deformity. Gunstock deformity is seen in cubitus varus deformity, that is your gunstock deformity, and it is seen in case of malunited supracondylar fracture of humerus. So ये दो important malunion deformities you need to remember. Okay? This is your March fracture, which is a type of stress fracture due to chronic repetitive stress, generally fracture of shaft of second or third metatarsal bones. Okay, now this is a fracture of lateral condyle of a humerus. Okay, and how did you identify it? First of all, this is your polychronon, etc. So this is your ulna, so this is your medial part, this is your head of the radius. Okay, and here there is one fracture. This is lateral condyle fracture of humerus. This is your dinner fork deformity. Polys fracture outstretched hand पे fall करने की वजह से होता है. Now next question is locking of the knee involves. We discussed it previously also. Here are your 30 seconds. Okay, so what happens is that the weight bearing is done by the lower limb, the pelvis, and the knees. So when you are standing on the ground, there is an inbuilt mechanism so that there is some rest given to this weight bearing part. Okay, and how do you give the rest with confirming that the balance of the body is mentioned, that is by locking of the knee. So whenever you will stand and the, with your foot touching on the ground, you can feel that yes, your knees are locked. And how they are locked, there is the foot on the ground, and how they are locked with in the femur condyles are locked over the tibial plateau with internal rotation of the femur. Okay, so the answer is your D, that is internal rotation of the femur with foot on the ground. As we have discussed, this is a natural phenomena. This is called as your physiological locking, which occurs in extension when the femur is internally or medially rotated on a fixed tibia, that is foot on the ground. This mechanism allows the knee to remain in the position of full extension as in standing without much muscular efforts, and is caused by the quadriceps femoris, because this form is the most important part for the extension of the knee joint. Okay, so the extensors of the knee are your quadriceps femoris. Okay, so this is your physiological that we have discussed. Now, true knee locking occurs due to some trauma when it is get physically stuck, and you physically can't move the knee for a period. That is, it is traumatic, generally due to the menisci injury. Okay, most commonly due to the menisci injury. Now, next question is, positive okay sign is seen in. Here are your 30 seconds. Okay, so this is your okay sign. Okay sign. This is your okay sign, that is adduction of the thumb, and this is called by the caused by the median nerve. Okay, so this okay sign is by the median nerve. Now, this posterior interosseous nerve is a branch and anterior interosseous nerve. Okay, so anterior interosseous nerve is a branch of median nerve, whereas this posterior interosseous nerve is a branch of radial nerve. Okay, so these are not the right answer. Now, injury or intact. So okay sign means you can do the okay sign. That means the anterior interosseous nerve or the median nerve is intact. If it is not intact, then you will not be able to do this okay sign, because the thenar eminency muscles are supplied by the median nerve. Okay, so ये ध्यान रखना. Pen test, if you ask a pen test positive, that means you are able to touch this pen due to abductor pollicis के action की वजह से. That means your median nerve is okay. But if you are not able to test that, that means there is median nerve palsy. Similarly, okay, you are able to form this sign, that is the okay sign. That means your median nerve is working. That means your anterior interosseous nerve is intact. So the answer will be B, that is anterior interosseous nerve is intact. Okay, so remember this. This is very important. Now, uh, s- these nerve injuries ke signs, especially the upper limb nerve injuries, is very important. Every examination, one question at least it comes from this part. Okay, this year also in every examination one question was at least from this part. So radial nerve mein you have the wrist drop, because it is concerned with the extensors of the forearm. Okay, sorry. And the radial nerve palsy is also called as the crutch paralysis, Saturday night palsy, the honeymoon or the lover's palsy, etc. The median nerve, it will lead to your pointing or the Ochsner's clasp in sign, like this. Okay, because they are concerned with the flexors and the thenar muscles and your first two lumbricals. Okay, and your flexors except, very important, flexors except flexor carpi ulnaris and medial part of the flexor digitorum profundus, and both of these are supplied by the ulnar nerve. Okay, so ulnar nerve mein you will have the flexor carpi ulnaris and medial part of the flexor digitorum profundus, and it supplies the hypothenar muscles, the third and fourth lumbricals, and the palmar and the dorsal interossei. ठीक है, and in median nerve you have the pointing osseous index. इसके अलावा you have the Benedict sign or sign of benediction, Benedict sign or the sign of benediction, and also you have the ape thumb. Whereas in ulnar nerve you have the claw hand, and claw hand is of two types, partial and the complete. So partial claw hand may you will only have the isolated ulnar nerve palsy, that is your little and the ring finger will be in little or ring finger will be affected. Whereas in case of complete claw hand, both ulnar as well as the complete claw hand is your ulnar as well as the median nerve palsy. Okay, remember this, this is important. Now hand ke andar the sensory supply or the skin supply is very very important. Okay, so you need to remember this, और ये कैसे रखना है. First of all, ulnar nerve is the medial. So the medial 1.5, that is your little and your ring fingers, anterior and posterior, both by the ulnar nerve. Now median nerve 3.5 fingers anteriorly, radial nerve 3.5 fingers posteriorly. But यहाँ पे the catch is that कि the median nerve, apart from the anterior 3.5 fingers, it have the supply from the skin from the posterior 3.5 fingers के this distal phalanx wala part also. Okay, so remember this, these things are very very important. At least one question in every examination comes from this part. So this is the okay sign or the circle sign. Now next, we have already discussed this, the test is given in the given in image is used for. So I'll give you just 30 seconds and jaldi se we'll discuss it, then we'll move ahead. Okay, so this is your flashy test or the occiput wall test, which we have discussed just right now. Ankylosing spondylitis के लिए करते हैं when the cervical vertebral column is affected. This is your ankylosing spondylitis. Okay, flashy test. Now next test. The following test is performed for. Here are your 30 seconds. So the following test is performed for rotator cuff muscle test करने के लिए. Okay, now in this first of all you should know the rotator cuff muscles. Now there are four rotator cuff muscles. First is your supraspinatus, second is your infraspinatus, third is your subscapularis, and fourth is your teres minor. Okay, these are your four rotator cuff muscles, and in case test is important. Now testing like this. Okay, this is your test for the subscapularis muscle. Okay, this and your lift off test. Okay, this is not lift off test, but this test and lift off test both are used for the subscapularis muscle. Okay, now तो subscapularis test के लिए this is your lift off test. Okay, this is your lift off test here. This is your bear hug test. This is your belly press test. The given image is of the belly press test. The belly press test, the lift off test, and your bear hug test for the subscapularis. Okay, for the supraspinatus you have this jobs or the empty can test. Okay, jobs or the empty can test, subscapularis or the lift off test. Okay, remember this. ओके, बस इतना याद रख लो क्या नेम है और किस मसल के लिए होता है, दैट्स इट. कैसे करते हैं यू डोंट नीड टू रिमेंबर, just remember it with the use of the photograph, that's it. Okay, now next question is true about pathological fracture is very common sense wala, very easy question. Okay, here are your 30 seconds. Okay, what is pathological fracture? Pathological fracture is a fracture due to trivial trauma. That means in a diseased bone or in a bone which is already weak. Okay, and what is trivial trauma? Trauma which generally does not cause any fracture, but if the bone is already weak due to some local disease or any systemic disease, then a very trivial trauma will cause the fracture. This is your pathological fracture, very common in osteoporosis, in osteomyelitis, in case of benign cysts or tumors, etc. This is your pathological fracture. Okay, so fracture is normal bone, no. Fracture in normal bone, no. फ्रैक्चर इन वीक बोन बाय ट्रिवियल ट्रॉमा, यस. इससे आगे का पढ़ना ही नहीं है बिकॉज नॉर्मल बोन में होता ही नहीं है. Okay, so fracture in weak bone by trivial trauma, so the answer is only third, not any of the above. Okay, remember this. This is your pathological fracture, and most common is your due to osteoporosis, and that too in the thoracolumbar spine, and that too in the thoracolumbar spine. Okay, now next question. Outermost covering of peripheral nerve is, here are your 30 seconds. Outermost covering of the peripheral nerve is, so outermost covering is the epineurium. Okay, so the entire nerve, it is your epineurium where it is, yes, here. And in the so epineurium, it contains fasciculi plus vessels, that is artery and vein. Okay, this is your perineurium. अब उसके अंदर क्या होता है, there are group of nerves which forms a single bundle which is called as fasciculi, and this fasciculi is covered with the epineurium. Okay, it is covered with the perineurium around each fasciculi, and inside fasciculi there are many nerves, and each nerve is then covered with the endoneurium, that is the individual axons. Okay, so epineurium, perineurium, then your endoneurium. Okay, remember. These are your fascicula, so this is your epineurium, and यहाँ पे there will be blood vessels etc. फिर उसके नीचे fascicula के चारों तरफ perineurium, then there will be endoneurium. Now next, sudden classification is used for very important. Here are your 30 seconds. Okay, so sudden classification, as we all know, it is used for the nerve injury. Okay, so yes, POTS paraplegia, it is a type of nerve injury also. So yes, the answer is 3, both A and B. So read the question carefully. And इसके अलावा एक और classification है, that is your Sunderland, sorry, that is your Sunderland classification. Okay, this is another classification for the nerve injuries. Okay, so remember this again, this is important, very frequently asked in the examination, whether you call it a part of physiology or ortho. Anyway, so Seddon's classification, there are three types: neuropraxia, axonautomesis, and neuroatomesis. As you all know, most of the nerve injuries, that is your radial nerve palsy in shaft humerus, your median nerve palsy in supracondylar humerus, or your sciatic nerve palsy in dislocation or any femur fracture etc., mostly all of these are neuropraxia. Okay, so in neuropraxia, it is a physiological condition where there is no discontinuity, there is no obvious nerve injury, there is no cut. Okay, so the prognosis is very good, recovery is spontaneous, 100% recovery is there, you don't need to do any surgery etc. Okay, whereas axonautomesis mein only the axon is damaged, so without any surgery, spontaneous recovery is there. It takes more time, and it is generally not 100%. Whereas neuratomesis is the complete break of the neuron, entire nerve. So what will happen is that there will be no spontaneous recovery, prognosis is very poor. Okay, remember this, you have to go for the surgery like tendon transfers etc. So this is your Seddon's classification. Now Sunderland classification mein you have 5 types, and axonautomesis ko it has divided into 3 more grades. Okay, based on this, grade 2, axon will be damaged, endoneurium intact. In grade 3, axon and endoneurium will be damaged, but perineurium will be intact. And in grade 4, axon and endoneurium and perineurium, all three will be damaged. Yani fasciculi level tak injury is there it is called as your axonotmesis. Okay, very important classification है, sudden classification especially, do remember this. Okay, and one more question that arises here is the best prognosis is of neuropraxia. Obviously we have discussed, and इसमें से भी किस nerve का, motor और sensory और mixed. Okay, so remember the best prognosis is for the purely motor nerve, example the radial nerve. That's why radial nerve ka prognosis is most. Okay, POTS paraplegia, we have all discussed about the POTS paraplegia, and इसमें you have a classification that you need to remember, which is called as your Tully's classification. Just name बहुत है, that is your Kumar and Tully's classification. What is this? This is your POTS paraplegia के अंदर the internal gibbus, which is a form of kyphotic deformity when it involves 2 to 3 spine. अगर सिंगल वर्टिब्रल कॉलम या सिंगल लेवल को अफेक्ट किया है, देन इट इज कॉल्ड एज योर नकल. then it is called as your knuckle, and agar more than 3 ko kiya hai, then it is a true kyphosis. Okay, now next question is, a 60-year-old man has intermittent pain in his right great toe for the past 2 years. X-ray is given. Which is the most likely cause for the lesion as shown? Here are your 30 seconds. Okay, so all these are features of gout. Grade to aate hi you need to, and if there is this erosive lesion and okay, it's like erosion, chronic erosive or destructive lesion of the grade toe, especially in the elderly age group, the only best diagnosis is your gout. So gout may you have purine metabolism में defect, so there is deposition of the uric acid crystals. Okay, there is deposition of the uric acid crystals or the urate crystals, but remember they are never in the form of calcium or phosphate salts. They are never in the form of calcium or phosphate salts. It is the characteristic feature of gout, and the so the answer will be a monosodium urate crystal deposits, that is A. And remember one more thing, that the lesion, the erosive lesion in case of gout is your rat bite erosion. Red bite erosions, and in microscopy these crystals that you see are needle shaped. Okay, they are needle shaped. Okay, this is your monosodium urate crystal deposition. Okay, gout we have discussed. Now there is one condition which is called as pseudo gout, where there is deposition of the pyrophosphate, but this can be in the form of calcium or phosphate salts, and most common is your knee joint involvement. Okay, and knee joint maybe there is menisci calcification. There is menisci calcification. Okay, so uric acid, calcium phosphate, needle like rhomboid. Birefringent में it is weakly positive, it is negative. We have seen red bite. And यहाँ पे menisci में you have calcification. So here you can see the white lines. These are called as the white lines of chondrocalcinosis, that is calcification of the chondro means cartilage. Okay, so white lines of chondrocalcinosis at the knee joint, that to the menisci. Here you can see this is your pseudo gout. This is your pseudo gout. Okay, so pseudo gout will be in more elderly population, whereas gout will be in the 50 to 60 years. And more severe is your pseudo gout, whereas sorry, gout and pseudo gout is your less severe. More severe is your gout. Okay, remember this. Now, next question. Read the question, then we'll discuss it. I'll give you 60 seconds for this question. Here are your 60 seconds. Okay, so a 33-year-old man with history of IV drug abuse presents with low back pain of increasing intensity. Neurological examination is intact. Laboratory studies reveal WBC count of 11,000 means it is raised. ESR 82 raised. Blood cultures negative. Plain radiographs shown. Initial management. Okay, and here you can see that there is some a lesion here. Okay, in the vertebra where there is complete destruction and erosion, and here also you can see. Okay, even in the soft tissue. So and it is IV drug abusers with increased count, ESR increase, so it is inflammatory, and that too any infectious causes there. Okay, so one thing is clear, that there is a infectious cause, and there is no neurological palsy or deficiency, that is neurologically it is intact. So physical therapy with supportive therapy, no, you have to first diagnose it and treat it, because there is a severe damage in the vertebral column. IV antibiotics, no, because remember, without making diagnosis, and at least without taking the sample for culture sensitivity etc., you should not start the antibiotics, because a single dose of IV antibiotics can make the pus culture sterile, and you will not be able to find the cause or the causative organism, or change the antibiotics accordingly. Okay, open surgical decompression and biopsy, no. Why? Because you don't have to do decompression, because the patient is neurologically intact. So the fourth option, CT guided biopsy, is the correct. And also remember, in case of pyogenic osteomyelitis of the vertebra etc., the investigation of choice if diagnosis is not made, that is for diagnosis the investigation of choice is your CT guided biopsy only, even in case of pyogenic osteomyelitis of the vertebral column, or even in case of port spine also, in all these cases. But if diagnosis has already made, then your investigation of choice changes to the MRI. Okay, so remember this is important. So the answer is your fourth, that is your CT guided closed biopsy. Okay. Pyogenic vertebral osteomyelitis seen in 50 to 60 years, diabetics and IV drug abuse में most common, and the most common pathogen is your Staph aureus. Okay, most common pathogen is your Staphylococcus aureus. Okay, remember this. Now, next question. It is a bit of difficult question, okay, but you should know this. So here are your 60 seconds for this question. Okay, so a 10-month-old child fell off the couch and has left elbow pain and swelling. Radiograph is shown. All of the following are characteristics of injury except. So here you can see there is some feature like dislocation of this elbow joint. Okay, so this is called as your transphysial injury, where there is transphysial epiphyseal injury at the end of the humerus. So high risk of tardy ulnar nerve palsy. No, tardy ulnar nerve palsy is seen in malunited fracture lateral condyle of humerus, and here fracture is not there. Posterior medial displacement, yes, posterior medial displacement is common. Child abuse is common, and there is high risk of cubitus varus deformity here. So the answer will be A. Okay, so this is your transphysial fracture or the distal humerus physial separation. ओके, सो इसमें तीन चीजें आइडेंटिफिकेशन एंड थ्री थिंग्स, दैट इज क्यूबिटस वायरस, posterior dislocation, and your high risk with child abuse is important. Okay, ये आपको याद रखना है. Now next question. 13-year-old boy with history of trivial trauma. Same image we have discussed. Okay, so very easy. Now here are your 30 seconds. Okay, so what is this? This is your fallen fragment sign. Pathological fracture in case of simple bone cyst or the unicameral bone cyst, that is option is B. So this is your answer. Okay, this is your answer. Now next question. Okay, I'll give you 60 seconds. Read the history अच्छे से, then the I will discuss the Okay, let's discuss it now. A 12-year-old boy is brought to the hospital by his mother because he has had intermittent pain in the right hip during the past 2 weeks. The patient ambulates, means walk with difficulty. There is no history of fever, chills, malaise, or recent illness or trauma to the hip. Uh, Patient is obese, otherwise healthy. Vague pain in the groin is elicited in the range of motion of the right hip. Most appropriate next step is X-ray studies to rule out which of the following conditions. Okay. So, firstly, there is no fever, no trauma. Yani, there is no um, infectious pathology, and patient can ambulate but with difficulty. So, there is no dislocation or fracture. Okay, there is no dislocation or fracture. Okay, so femoral acetabular impingement syndrome, it will not be in your case because it is a chronic condition, but there is some bursitis, etc., trochanteric bursitis, etc., fibrosis, which will lead to impingement. So the symptoms will be more of stiffness, etc. Okay, so this is not the answer. Septic arthritis नहीं है, tear of the labrum नहीं है. So it is a typical feature of slipped capitofemoral epiphysis, that is SCFE, because a characteristic thing that is given here, it is your obese. So obese in 10 to 18 years of the age group, that to boys. Okay, all these are features of the slip capitofemoral epiphysis. नाम से पता चल रहा है that the epiphysis of the femur head will be slipped. Okay, like this. Here you can see this is your normal, and this is your slipped capitofemoral epiphysis. Here you can see that this epiphysis has slipped away from the rest of the bone. So this will lead to growth plate disturbances. Okay, this will lead to growth plate disturbances, shortening, etc. So it is a very important thing to treat, otherwise there will be permanent shortening, because it is the age where the growth of the bone takes place. Okay, so this is a slipped capitofemoral epiphysis. Okay, so adolescent 10 to 18 years of the age group, the growth plate is damaged, and femur head, that is the epiphysis, moves or slips. Okay, and obese males with endocrine disorders are at high risk. Single greatest risk आपसे कोई भी पूछे, that is your obesity, and there will be groin and thigh pain as the most common presentation. And इस classification का सिर्फ name याद रखना है, that is your loader classification for the slipped capitofemoral epiphysis. That's it. Okay, here you can see this is your epiphysis, this is your metaphysis, this is your diaphysis, and beach mein this is your growth plate, which is called as your physis. Okay, remember this. Now next question, I'll give you 60 seconds to answer this question, then we'll discuss it अच्छे से. Okay, so a 19-year-old man, long distance runner, is referred by his primary care provider because he has dull aching pain in his right thigh after running during the past 9 months. 6 months ago, the patient's primary care provider prescribed ibuprofen, which relieves the pain temporarily. Patient has no history of any specific injury, that means no history of trauma. There is no abnormalities of the right lower extremity. X-ray shows right femur with cortical thickening of the distal one-third of the shaft with central nidus approximately 8 mm in diameter. Which of the following is the most likely diagnosis? Okay, so there is a lesion here. ये सब फालतू की चीज है. Last three lines से you can make the diagnosis. So a nidus with central nidus with thickening or like this, or sclerosis like this around, it can be seen in two conditions. First is your osteoid osteoma, and second is your osteoblastoma. In aneurysmal bones, there will be a lytic lesion. In enchondroma, again lytic lesion hota hai, and osteochondroma mein you will have the cartilaginous and calcified spicules. So दो चीजें बची, osteoblastoma and osteoid and both have the same picture. So here, you can differentiate these two by the help of size of this central nidus. By the size of this central nidus, and the this is the differentiation. And कैसे करते हैं? If it is more than 2 centimeter, that is 20 mm, then it is osteoblastoma. And if it is less than 2 centimeter, then it is osteoid, and here it is 8 mm, that is 0.8 centimeter. So the answer is your osteoid osteoma. Okay, so the answer is osteoid osteoma. Okay, this is the osteoid osteoma, sclerotic with central nidus here. Okay, central nidus with sclerosis all around, osteoid osteoma. Okay, what is this? This is your aneurysmal bone cyst. Metaphyseal होता है, eccentric like with septa but less septa as compared to the simple bone cyst. Bubbly appearance होता है. There is no mineralization, no calcified spicules. This is your osteochondroma with calcified punctate calcification. Okay, this is your osteochondroma. Okay, now next question is, a patient presented to the trauma with obvious deformity of the right femur and left forearm following RTA, intubated in the trauma bay. Both injuries are closed. How would you manage this injury? Here are your 60 seconds for this question. ओके, सो वेरी इजी. क्लोज्ड इंजरी है फर्स्टली, तो ओपन नहीं है, सो वी कैन इजीली. नाउ अगर ओपन होती है तो यू गो फॉर द एक्सटर्नल फिक्सेशन, सो क्लोज्ड है, यू गो फॉर द इंटरनल फिक्सेशन. नाउ एक्सरे से भी पता चल रहा है दैट इट इज एन एडल्ट, द पेशेंट इज नॉट चाइल्ड. And there is two fractures. First is fracture shaft of femur, and second is your fracture both bone of forearms. Okay, both are displaced, so the treatment of choice is surgery for both of these. So here you'll go for the nailing of the femur, that is criff with ILN femur, and in forearms you go for the plating, that is orifice with plating. Okay, so the answer is femur mein you go for the criff and forearm mein orif. So the answer is your D. Okay, D is your answer. So as a rule of law, remember, we'll start from the clavicle. Clavicle mein you have the clavicle brace, that is figure of 8 bandage. Then for the humerus, you go for the conservative mostly, but plate अपन अब बात करेंगे only surgery, then you go for the plating. Okay, and for the elbow injuries like lateral condyle or medial condyle or supracondylar, तो child है you go for the K wire, and in case of adult you go for the plating. In case of both bone forearm or isolated forearm bone fracture, in both of these you go for the plating. Okay, now in fingers के लिए you go for the K wires, metacarpal के लिए भी K wire, for the Colles fracture etc. either you go for the external fixator, the just fixator or plating. Okay, now we'll come to the lower limb. Lower limb में for fracture neck of femur, in adults or young adults you go for CC screw or DHS, whereas in the elderly population you go for the bipolar hemiarthroplasty. IT femur के लिए you go for the PFN nail. For fracture of femur you go for the ILN femur. Okay, now for fracture of distal femur or proximal tibia you go for plating. For patella you go for the tension band wiring, TBW, and TBW is also for another two fractures, that is your olecranon and your medial malleoli. Okay, and इसके अलावा below patella for tibia fracture you go for ILN tibia. Femur fracture only distal fibula, only distal fibula is treated by surgery, rest fibula conservative because it is not functional. Okay, so these are the different types of implants or surgery you do. And as a rule of law, remember, nailing is grip, whereas plating or TBW is your ORIF, and K-wire can be both CRIF as well as ORIF. K-wire can be both CRIF as well as the ORIF. K-wire can be both. Okay, so remember this thing, this is important and this will help you to solve many questions. Okay, so just remember this. Now next question, and I'll give you 60 seconds for this question, then we'll discuss it अच्छे से. Okay, so a 34-year-old female complained of left leg pain after she was struck by a moving vehicle. She denies pain elsewhere. 3.5 to 3 centimeter open wound about the medial aspect of the left leg with exposed bone. otherwise skin intact. Compartments are soft and compressible, that is no compartment syndrome. वैसे भी open or compound injury में there is no compartment syndrome. She has appropriate pain with passive range of motion of toes and ankle, motor sensory intact, palpable dorsalis pedis and posterior tibial pulse, brisk capillary refill in all five toes. What would be the treatment? Here is the photograph and the x-ray. So this is a open fracture of tibia with proximal fibula, and इसमें you will not do anything. Okay, so open fracture of tibia and neurovascularly it is intact. Okay, so conservatively, no, you cannot go, at least debridement etc you need to do. Island tibia, yes. Or if plating, no. Or k-wire, नो. सो द आंसर इज आइलैंड टिबिया. बट अगर इसमें एक्सटर्नल फिक्सेशन भी होता, सो एक्सटर्नल फिक्सेशन, दैट इज एक्सटर्नल फिक्सेटर will be preferred over island tibia. Okay, so agar option mein external fixator would have been there, then the answer would be the external fixator. Okay, so remember this thing, because already इतना ज़्यादा open compound wound में if you go for internal fixation, that is you put a implant inside the bone, okay, then you have high chances of infection, and that will affect the entire bone, and there will be non-union, weakness of bone, pathological fractures etc. So and remember, infections of bones are very hard to treat. Okay, so that's why external fixation is preferred in case of compound or open fractures. Okay, so इसके लिए you have a classification very importantly which is called as your Gustilo-Anderson classification. Okay, remember this name, that is your Gustilo-Anderson classification, which is important. Okay, here you have type 1, type 2, type 3, 3A, B and C. Okay. Type 1 is only a abrasion or puncture wound, where you can very easily go for the internal fixation. Okay, now second is your lacerated wound but less than 2 centimeter and clean, not contaminated. Here you have more than 2 centimeter lacerated wound, contaminated etc. In B 3B you have the crush injury, severely crushed or near total amputation, or you can have the bone exposing wound, bone loss wound etc. And C is your neurovascular injury, if there is any vessel cut or arterial cut or any nerve cut, so it is a emergency, especially the vascular injury. Okay, so this is your Gustilo-Anderson classification. Now we'll come to the next question. Next question is, I guess we have discussed lots of questions today. So remaining, I have approximately only 5-10 questions. So I'll put some clinical questions. Last 4-5 questions were clinical questions and they were good. I hope you like them. So ऐसे ही clinical questions का I'll make a separate class, and we'll discuss some 10-15 clinical questions like this in a another class. Okay, so that was all for today. Thanks for watching. Okay, and if you like my video, please like, share and subscribe, and watch my other videos on the YouTube as well as the special classes. At 9 p.m. we have a special class on ligaments of knee, and at 10:30 p.m. I have a again YouTube live classes where we'll revise entire orthopedics with the images. Okay, a marathon, again a marathon long session where we will discuss all images, relevant images, and सिंपल स्मॉल रेलिवेंट थ्योरीज अबाउट दैट. ओके, उसको अपन ज़्यादा थ्योरेटिकल नहीं बनाएंगे, जस्ट वी विल लर्न अबाउट द images. So it will be again a very good session. Okay, so see you there at 9 p.m. in special class, 10:30 p.m. YouTube live session, and you can use my code, that is Anshul B10, while subscribing for any of the subscription packages on the Unacademy, and you can get extra 10% off. Okay, so thanks for watching. See you in the special class at 9 p.m. Till then, bye bye. Thank you.